Okay, so welcome to this month's AAAC seminar. I'm Lola Calimero, your host, and it's a great pleasure to welcome Nadia Berthouze from University College London, that I've known for a very long time, and probably most of you have known for a very long time as well, because she's been really involved in the affective computing community from the beginning. So again, she doesn't need a presentation, but I'm going to introduce her. I'm going to read a little bio that we prepared. So Nadia Berthouze is a full professor of affective computing and interaction at the University College London Interaction Centre, UCLIC. And her research focuses on designing technology that can sense the affective state of its user and use that information to tailor the interaction process. She has pioneered the field of affective computing by investigating how body movement and touch behavior can be used as a means to recognize and measure the quality of the user experience. So her work has been motivated by real-world applications and to mention some physical rehabilitation, textile design, and education and well-being, human manufacturing. She has published an awful lot of papers, over 100, in affective computing, human-computer interaction, and pattern recognition. So that's my little introduction. Thank you very much, Nadia, for accepting our invitation.
Well, thank you very much, Lola, for inviting me, and for everybody that is here. Thanks for being here for me today. As Lola said, I've been working in this field for a long time, and I really enjoy the challenges, but also what we discover and what we can do for people. I work across a variety of areas in terms of a real-life application, but I really like the work we're doing on physical rehabilitation. We are working in this area for a long time, and beyond thinking of how to design this technology that is more effective for people who need to do physical rehabilitation. It also hello.
Sorry, people should mute themselves. You should have been muted at the start, so you should remain muted for the duration of the presentation. Nadia, I think I cannot mute them.
Okay. I thought it was a question to me. Yeah. So for me, it's a really
sorry, Nadia, because I'm not the host now. You will have to.
I have to mute them.
Yeah. So you will see, perfect. So people, please remain muted for the duration of the talk, and then if you have questions, you can start writing them in the chat, or you can afterwards, when the questions and answer session opens, then you can ask them, but maybe it's better to put them in the chat. But please keep your microphones and your cameras switched off during the talk. Thank you. Okay,
thank you. So I'll say that I'm very interested in this area, and not only we can provide make an impact on people's life, but we also learn a lot from this area, and in terms of how affective technology can be designed across a variety of sectors. In this talk, I will focus on this work and I will show some old work and some more recent work we are doing in chronic pain and related area. And we say that many people have contributed to this work, not just me. So thanks to all my collaborators here. And so when we started to work on physical rehabilitation, we're going to see a lot of new technology emerging as a way to make physical rehabilitation more interesting, and games and Kinect were the main contributor to those new way of thinking about physical rehabilitation. Nowadays, we have many more opportunity offered by technology, not just in the home, but also outside or ubiquitous. We have apps that can run on our smartphone or larger mirror, and they can track our body. They are used for physical exercise, but they become also very useful in physical rehabilitation, where you can provide feedback on how a movement is done and correct the movement, with the idea that if you perform the movement better, the exercise is more effective. And of course, you have many more other technology and badges and a lot of feedback that are really rewarding and motivating. Unfortunately, most of this technology only is based mainly on this fun, performance, perfect movement, and how much you're doing of it, and badges, and see this as a motivator for overcoming barrier that physical rehabilitation creates to people, mainly due to frustration and also the pain people feel. But when you work with a patient, you realize that that's not always the main barrier to them. It's not just the lack of motivation, the laziness, the repetition of the movement, but there are a lot of affective barriers that bring them to disengage with movement. And this is in particular with people who live with a long-term condition and not just a short-term problem like a sprain or a small surgery. But in our project, we focus on a particular condition that is chronic pain, and chronic pain may exist in itself or often found in combination with other conditions like stroke, or many more conditions may lead to chronic pain. But in our work, we focus on people with chronic pain without other conditions related to it. And what we already see here, a lot of patients got really angry at us when we were thinking, oh, we can design games that can help you to exercise also in the comfort of your home, and by making it less frustrating, more motivating, providing a lot of feedback about how you're doing. And there was this anger, say, we are very motivated, but there is a fear that is even unconscious, that is triggered by pain, and movement trigger that fear, despite movement may not be the cause or the danger in that moment. And just a few words for people who don't know much about chronic pain, but chronic pain, differently from pain, is maladaptive in the sense that instead of being a good response that help people to protect themselves from further injury, it's just due to a malfunctioning pain system that does create or trigger pain. But this pain is not due to an injury or a problem with your tissue, inflammation in the tissue. There is no problem from that perspective, but it's just a question of a pain system that is not working properly. And unfortunately, this trigger is still pain, and so trigger this need, this automatic need to protect yourself. And the first thing you do is stop moving. So the way we started to think and to approach this problem is, how do we bring the affective needs of the person? How do we address the affective barrier? And what are these affective barriers to engage with physical activity? So you can find more detail in our paper, but just we run a lot of study from a human-computer interaction perspective, so HCI perspective. We work with a variety of stakeholders. First of all, people suffering from or living with chronic pain, and psychologists, the physiotherapists, and clinicians that would be part of a team of supporting people in learning how to manage their condition and how to learn to engage, overcome the fear of engaging in physical activity. We work both in the lab, in drop-in session at the hospital, program on chronic pain at the hospital, and we also observe people in their home, and we work with them on their home to understand how they engage in physical activity. And what emerged from here is a kind of framework that provided some guidelines on what it meant to design technology that can help people to better understand their own capability, build confidence in their own capability. And one thing that came out very strongly from the clinician was to avoiding giving an idea of perfect movement and safe movement, but we had to transmit the idea that movement was always better than not moving. What we had to focus more was developing a positive awareness of your movement, and also of the sensation that you may feel from moving. And also reducing the chance for increasing anxiety by avoiding pushing people to do activity despite they physically could do them, but if psychologically they couldn't, the technology had to support them from that perspective. And more importantly is that they would be the people in charge of the physical rehabilitation. So it's not the clinical model where the physiotherapists decide what the person do, but physical rehabilitation in chronic pain is mainly outside the clinic, is in everyday life. So it's a person needing to have the confidence to know how much they should do in that day and what would be beneficial and what would be overdoing. So that taking control was an important aspect of our work. And we look at and observe, as I say, a lot of physiotherapists, and it's just to give you an idea that one of the moment on which the physiotherapist was explaining how he was not instructing people, but he was exposing people to their natural sensation of movement, with the idea also to create a sense of moving and normalizing any sensations, and say we would be with them, we would do the movement, and as we do the movement we describe the movement rather than organize it as an exercise that is pre-instructed, and because that would trigger anxiety. And as they do the movement, naturalize and start to say we feel a little bit of stretch, we are reaching the knee. And it's interesting because not only they were paying careful attention to normalize sensation, but there was also this in the way they were talking, they were highlighting, enhancing the sense of moving. And it's interesting, we did observation with them, and then we interviewed them by looking at the video we created of their session. And there was a lot of discovery by themselves, because a lot was from the book, but a lot was from experience. And sometimes you're not aware of all the strategies you learn, and they're very effective. So there was a learning on their side, in which they went on and wrote a paper on this. But there was for example, the use of a continuous tense, because that would give a sense of doing, of being in movement, rather than a description of the movement in a present tense or as an instruction. Anyway, taking from all the learning we've done by working with a patient and a clinician, and trying to match the different perspective they had, and sometimes really opposite perspective, one triggered by fear, the other triggered by inviting to movement, we developed a variety of devices that were designed with the affective needs or the affective barrier in mind, rather than with the correction of the movement. Here is just an example based on a smartphone. We had other based on Kinect, on a TV type of situation. But this was also the most effective, so I just focus on this one, but you can imagine you can implement it in many ways. Here we use the movement sensor in the smartphone, and we trigger, in this case, just the one degree of freedom, that was the bending of the trunk, and transform real-time the bending of the trunk in sound. And we also had other type of sensor, breathing sensor, that we also explore, and you can see more of this in the paper. And I just focus here on the sound of the movement.
Starting position.
So I am not sure how much you can hear, but so here we're showing one person with chronic pain engaging in physical activity. This person is hypermobile, so she can bend a lot. You have the opposite. You have people that don't move much, or you have the person that hypermobile, move too much. In both cases, they have the condition of chronic pain, and chronic pain is still live with this feedback of pain, and that create fear of movement and lead to, as you will see, to some protective behavior, with some more extreme than other. But what happened here is, after the person is wearing the mobile phone on the back, and the researcher here, Anisha Singh, is calibrating now the sound to the the movement, amount of movement they want to do, identifying an intermediate point where they still feel comfortable stretching forward, and the maximum point where they want to arrive, beyond which there will be no sound.
Position. I've done it. When you're most comfortable.
So here is the most comfortable.
Comfortable positions. And your maximum for today.
And then the maximum.
Maximum positions. That's great.
So you can see some protective behavior here.
And you could just. So it flattens out after that.
So we did a lot of study with patients and then people with chronic pain, and what emerged as people reported that with the sound, and here is the sound, you saw it going up to the point that you the movement feel comfortable, and then down to the maximum amount of movement they want to do in that day. So this 3-point information with a continued increase, with a sense of enhancing the sense of moving, as you hear the change in notes, you feel the sense of progress. People felt that they were not just encouraged, but there were a sense of knowing that the body was doing something, and they had a feeling of where they was, because it was decided by them what those points meant. So that was important for building their own sense of control on themselves and decision making. But without the sound, many thought that they didn't know what their body was doing, and that increased anxiety. So these were very positive results, and there was a variety of study we did, control study and focus group, so you can see more detail in the papers. But what emerged from the focus group is that for them, exercise was not the most important activity when they were outside of the clinic. Outside of the clinic, physical rehabilitation for them meant something else, and was fully integrated in their everyday functioning activity they had to do because they had to contribute to their family, or because they also their activity about entertainment activity, work that required that movement. So if they had to move, that had to be within the functioning, because the resources are very limited, and they couldn't be dedicated to both activity. So people who had learned to integrate physical activity in their life, they would integrate it into their daily activity. For example, here, the home chore would become the stretching activity, or the carrying load activity, as you would for shopping. Organization of the house was also done in a way that, instead of putting everything around you so you don't have to move and avoid engaging in physical activity, people had learned to manage and engage in physical activity. They were even reorganize their house so that they would get them to do some physical activity. And there was also in the house put in such a way that would remind them that they cannot just start an activity and just rush through it to try to get on and finish it quickly, but they had to take pauses. Otherwise, the pain would increase, because the muscle would become very tense. So we would have carpet close to the washing machine, or a chair that will remind them to do exercise every other dish or so, and so on. So it was completely integrated in their life. and not at all as just an exercise. Here, I think you will not hear the sound, unfortunately. Something is wrong. We have tested before. But so unfortunately, you can't hear the sound. But if you can imagine the sound you heard before, this person is doing their own everyday activity, chore activity, wearing the phone on the back and practically transforming their movement into sound. It's quite understandable for people who may not need that, but for them, it was very interesting how for them that was information. For many of them, initially they calibrate the device, the sound, to what they thought was the maximum stretch they could do, so that they would know when they are going beyond as they engage in physical activity in their home. But then they realized that often they were going beyond that when they were not too focused on the activity itself. So they started to use the sound in another way, and they calibrated to the amount of movement that the activity will need. So in the case of the loading machine and going down to the floor, pick up the clothes, that would be the full movement would be sonified and include a return. For them, the sound, they talk about the sound becoming their body, and being able to attend to the sound as not a scary stimuli, but attend to the sound and using it to then apply strategies that they learn with the physiotherapist or with the coach, and apply it not just to exercise, but see the relationship between the same movement in exercise and in the body movement in the functional activity itself. So what emerged from them, and it came really from them, we are planning just to design it for exercise, but they wanted to try this device in their house, and they saw the opportunity for that, for re-engaging on the physical activity. They use it across 1 or 2 weeks, according to initially was one for some people they went on, and they saw it as something that allow them to relearn about their body. People went even outside of the home, because outside of the home the anxiety is much higher, and there was this relearning, of course, with some social laughing, because you're making sound and people may ask you. But it was very interesting on how after 10 days there was a lot of increased confidence in what their body could do, and they saw it as something that they could reuse it each time they have a setback, as chronic pain, unfortunately, is not something you get better, but is a cycle condition. You have pain, bad days or bad period and good period. And when you get out of a bad period, it's very hard to go back to engage in physical activity again. What also emerged from the participant itself, despite we were already working on this, it was the need of a device that help them to become more aware of what they can really do, as often they are either their attention is devoted to the task or the attention is devoted to pain, and often they don't even know how much they have done. The sound was helping, but they wanted for something much smarter and allow them to reflect more on what they can do, what work, what doesn't in their home organization, and even helping them reorganize in their home. But they wanted something that could understand when they were doing a movement, because they had to do, there was no way they could avoid to do it, and a moment in which they can do it without being anxious of and strong pain. So something smart that can read pain, expression, anxiety, and use that information to support them better. So in parallel, we work on building a system that could detect expression of anxiety, hesitation, and possible pain, increased pain. And from the literature review on chronic pain, there is a quite nice literature review describing body expression as call it a protective behavior, pain-related behavior that is linked very much to anxiety rather than, again, a physical limitation. And it's generally triggered by this fear of engaging in exercise due to pain. But of course, it could be also, is also what is portrayed when you do feel an increase in pain or pain itself. We have in this data set, we have we have also facial expression, and vocal expression, but here we focus on what we are doing on body movement, because what emerged on the literature that in the case of chronic pain, body movement is very meaningful, because you are living, it's not a moment of acute pain in which you see it in the face, but it's something you live and you learn to live with. It's much more expressed through those behavior, and that behavior also telling you something about the difficulty or the way you think your body can or cannot cope with it. So using this data set, we have Explore, we have an in-depth exploration of how protective behavior appear in the motion capture sensor and in the muscle activity sensor, with here a normal pattern of behavior, for example, for that stretching movement. And here an activation of people with chronic pain that don't relax their muscle, because you remain constrained even when you return in standing position for the fear of feeling pain, or not engaging at all in a movement. We develop a variety, we propose a variety of architecture to explore, a variety of architecture to improve the recognition of pain behavior and pain level. Here I'm just showing one of them, one of the recent one, which we are doing, we are trying to improve the recognition of pain by combining the recognition of the activity the person is doing, so HAR, human activity recognition, with the detection of protective behavior, because the protective behavior depends on what you're doing and how the person feels that they can perform that movement. We have another version where we also integrate the EMG into it, and we explore how the fusion between these two modalities should occur given the alteration of a normal activity that is due to this fear of pain. And it's very interesting how the fusion that lead a better result is at intermediate level, is really between models rather than early or late fusion, as because of the variation and the variety of model people build on what is good for them and what is dangerous for them. So here I'm just showing some result to in terms of activity recognition. Here there are 5 activities we work on: standing on one foot, reaching forward, sit to stand, bending down to the floor, and any other activity in which we don't have a real segmentation, but activity people do just to relax between activity. We chose this movement because they are proposed by the clinician. These are the movement they also explore in the pain management session at the hospital, because they are everyday activity, or say building blocks of everyday activity. Standing on one foot is what you need to do to walk or even to climb the stairs. Reaching forward, you reach forward to wash the trunk of your car, the roof of your car, to take a book from a shelf. And of course, bending down, you take something, fall down on the floor, you tie your shoes, and sit to stand are, of course, a normal activity. So we work on that as building blocks, with the idea on one side of being a proof of concept. People were left to do this movement on their own, according to what they felt they could do, a different level of difficulty. But the reason I'm showing this last model is that for me it's really important, and all my work is about working in the real situation where people live and are going to use that technology and where they need help. So that for us was the first starting step. And what we're doing now is to build a new version of the emo pain data set. We presented last year at AAAC, but it's still growing. So we have more data now in the data set. And this is data set built in people's home, while they're doing their real functional activity. So they can choose activity they like, an activity they found more challenges. And we are asking them to leave there to do any activity they need to do and not simulating them at all. And also we do also qualitative study with them to understand how this technology can get in their home and also how they feel their role. So you can see here some example, hanging their clothes, vacuum cleaning, arranging their kitchen, and you have many more. And we also have the same activity performed by healthy people, and they were performed on over different days, so that we may get them in different moment of different pain level. See here is for the moment last year's the slides, we haven't updated yet, but I can see the variety of activity that could be clustered in a smaller and high level group. But you also can see the different level of pain according to activity they are not afraid of, or activity that are finding more challenging. And you can see also how this spread across the different participants. So there is a good variation for each person and different activity in terms of pain level and activity they are doing. So the reason I show the architecture before, that is based on a graphic structure of the body, and was aimed to recognize activity that we're considering the building block of more complex everyday activity. Is that now we are starting to apply this to a more real life activity, as you can see here, and started to explore how this architecture may work in a very, very noisy type of data set, and also data set with reduced number of sensors, as we have to make it work in real life. And in this case, people had to wear it themselves. The researcher was not with them. So it has to be something manageable. We're getting very interesting results, and this is just in preparation. And in the next publication, there will be also result for the recognition of pain using a more complex architecture that take advantage of existing data sets that are larger and easier to gather and then tested on tuned to this real life data set. But talking about data set, we have done in data set in the context of body movement. Affective body movement is still a big problem. On facial recognition, now we have very, very large data set. I'm not saying that there we still need more data, but in the area of body movement, data set on affect are still lacking. And we have done, and I say, Tammy Olugbade did a lot of the work here. We've done a scoping review where we have looked at all data sets available across discipline, not only in affective computing and not only related to affect, just to see what data sets are available there that we can reuse to build architecture that are more powerful, and that we can also reuse for building architecture that for situations like chronic pain, where collecting larger data set is more demanding for people. And we can see here the spread of data set, how it's still limited, despite we have 700, identify 700 open data set. There are more there, but they're not easily available. And you can see how this is very concentrated in particular area of the world. And if we think about rehabilitation, the rehabilitation is the need for rehabilitation, for support rehabilitation, is very spread. If we just look at low back pain, the one I've been talking about here, you can see how spread it is, and not just in the area where the data set were gathered. So there is a big need for better data set. This scoping review provides many more analysis of this data set, and I'm showing you just a few glimpses on it. So, but there is it's a very interesting resource for people who are looking to data set working on body movement. We can see here what I was saying, how affect is still lacking behind data set for action. And so there is a lot of work to do here as a community. We can see here the type of activity we can categorize this large data set. And another interesting observation here is that more of the data set are collecting on general population. We have very little on a spatial population with particular condition or particular disability, and that make the work of recognizing those affective states that matter in those conditions and integrate those in the technology that is emerging for facilitating physical rehabilitation or other form of activity where affect is important, still very difficult because we don't have enough data to deploy system that may work in real life. So go to see the scoping review if you're interested in data set. And at the end, we propose also a framework how we have to work as an interdisciplinary community, even outside the affective computing community, in considering how we collect data and create data set, and we share data set in a way that are reusable beyond the initial purpose of that specific researcher, but also how we make them inclusive so that they go beyond the what is considered normal body, but consider the both a physical body configuration, but also other conditions that may impact on body. And what we are missing a lot, as you see the paper, is data set that are collected in the wild and bring that noisiness, but that variety that is important and is very, in itself, a meaning in the specific context in which that is exhibited. So just to summarize this first part of the work, and if there is a little bit of time, I will touch upon touch. So affective barrier are critical, but if we look at the technology that is designed for supported any form of physical rehabilitation from acute to chronic, or for other type of condition, not just for acute pain, we see that there is very, very little attention to affective needs. And often there is an oversimplification of what can be motivating and engaging. So there is a need to, as a community, I think we have a need to understand how we can contribute to that work. And also we need to understand the condition that we are dealing with more. It's important that we understand the condition and we work with the people who understand the condition, because otherwise we may design for something that is very complex and from a technological perspective, but it may fail and may be not used by those participants. And awareness of movement is very important across a variety of conditions. We have other examples that I didn't report here. And we also have to think at the ubiquitousness. We have a lot of technology that is based on a feet camera, but a lot of our life is not in front of a camera. It may occur in places where we may have distributed sensor, but we need to think that no matter what sensor we use, the wearable is just one. How we understand the space in which that technology is going to be used, and how we bring our affective technology within our affective capability within that ubiquitous and complex space that is life. We need to consider also that a lot of data set in affect computing is either about expressing affect or activity recognition, so action, and it's important to think that those occur generally together. So you don't have activity without affect, and you don't have affect without activity most of the time. So we need to think about gathering those data to empower the way we support people. and data sets. So data sets are critical and should be more inclusive. And also, most of the data set we found are individual, one person, and our two. So we are also guilty. But it's our life is generally an interaction, and those interaction modify the way we use our body for many reasons, either just of social interaction, but also how we do activity when we cooperate with another person. So it's very important that we think about going away from just individual data set, but spanning a core that more social interactive role that the body plays. And I would like to conclude with a small presentation of a new work we are doing. So I'm increasingly working in the context of touch. I've been studying touch in the context of designing technology for textile and sustainability. So we are doing a lot of work there, but we also have started to look at touch in the clinical context. And this is really initial work, but it's part of a larger grant. And with my colleague here, we are preparing a paper. So hopefully the result will be available. But I just give you a glimpse of the work we are doing and a couple of messages. First of all, this is a part of a larger grant on robotics, on embodied intelligence, going from sensing to collaboration. And we work across a variety of application domains, and one of them is social care. And so the work I'm presenting here is just one of the scenario we are investigating. We are working with occupational therapists with the idea to bring robots in the context of occupational therapist work. It could be as a co-worker, or it could be as a robot that simulate a client or a patient according to the language used, because during the training session, as a lot of training sessions are based on occupational therapists simulating to be a patient, but they recognize how limiting that is, as they don't have the condition, and also they cannot deform their body to reflect the problem that the person has. So there are a lot of limitation of using such a setting bring. But what we are particularly interested in this work is, again, the overlapping between instrumental touch and affective touch. We have done a larger literature that is now systematic literature that is now under review, where we have reviewed all the paper study touch in the context of care. Medical care, occupational therapy, physiotherapy, a variety, so all that domain, and we're looking at how they study touch and of course what we know about how it is used. And there is either study on instrumental touch or empathic touch. There are very, very few studies that think they occur at the same time, and how one modulate the other. And there are some initial work that is pointing in that direction. So what we have done here is to study with occupational therapists how they interact and how they modulate their instrumental touch during while they are working with their client or their patient. We use interview, and we also run a real training session in which occupational therapy were taught to how to assess the sitting position of patients. So these are typical training session they get also refreshment session. And so we took part in those, and we work with the organizer to adapt that session to bring some human interaction approaches to get people to reflect and become more aware on how they use touch and affective touch. One interesting finding from there is that despite affective touch is very critical, very important to them, there is no training about its role and how it should be used. It's all based on experience, and trainee is something that for them is at a beginning a big something that is scary, not knowing how to deal with those affective aspects. And we had reenactment station, and we had other variety of station, and also skin sensation station. As we developed the robot, we also, as a simulated patient, we want to understand what kind of sensation of the skin of the patient should reveal or provide to the occupational therapist to understand their client better. So the paper will have a lot of various themes that emerge here, bring together into 6 themes, and you will sign more as if the paper will be accepted. But what I just want to do, as for sake of time, is just to give you 2 vignettes that my colleague Mina Nygren has designed based on all the video and the result that emerge from this enactment station, and how the touch is used. The touch is used. The affective touch is modulated to address the psychological need of the patient, but also it helps to build rapport and trust build the trust in the occupational therapist from the patient. So there is a lot of many instances of modulation emerge in different way through the enactment and reenactment. So reflection on between the simulated, the occupational therapist simulating the patient and the physiotherapist doing the assessment, and also a lot of description and recognition of how the use of touch is a journey, not just a journey as an occupational therapist as you become more experienced, but it's also a journey as you learn about that particular patient, because it's very, very based on the relationship between you and that particular person, rather than a standard of the book way of interacting with a person. And here are the little vignette. Here is an example. So we always had an enactment where they had a scenario set by the occupational therapist directing the session, on which a patient was the client simulated by the occupational therapist had to play a particular condition or particular state, and the occupational therapist has to run the assessment of the sitting. And you can see here they are interacting, and how the occupational therapist respond as this is reading some either body reaction and facial or vocal reaction. And in the reenactment, so as they reflect what emerged in their discussion between them on how one perceived the movement and the changes in the movement, the modulation. So the patient, the simulated patient therapist, who say that she felt the other person understood that she was expressing pain, and what she has done, she had released slightly the hand, not remove it, just as you see here, she is playing with the hand a little, relaxing that for then coming back to it. And so they started to discuss on how that often is done, and those are really important, because if the person is really feeling pain in the moment, you don't want to stress him more, but how those start to create a sense of I understood. I am understood by the occupational therapist. He understands me, he reads me. So there is a trust that is start to emerge. And so the client can start to relax, because they feel that it's more that the person is caring about and knows what it does. Another thing that emerge is also, that is not described here, but the movement of the hand and the touch is very important. For example, the confidence of which the grip is made. So many trainees say we don't dare to go there, so we start to fidget or hesitate, and that is read as hesitation. And so the feeling on the patient that the person doesn't know exactly what they're doing. So even if instrumental touch may be correct, but that hesitation or that not strong enough grip, you may be too soft because you don't want to make pain, but that convey lack of confidence. So there is a lot of negotiation here, and that's why also depend on the particular client rather than being the set of rule that can be applied easily to any situation. But there is that modulation that does not just take in that solve the problem of reducing pain, but bring those other important affective aspects to the space. And here is another one, another shape of hands. Here is readjusting the person to sit better on their seat, and how they have to modulate between using the finger and poking and the person. And even if that it's a more precise gesture to feel the bone and understand how they reassess them. They often alternate between what they call pancake hand, very large open up hands on the side, that give the sense to the patient of feeling kept. And again, that sense of control I was saying before. And at the same time, that need to be combined with the confidence of touching and going into poking in a particular way, possibly all the hands rather than just one finger, because you have more control, so you can control how much pressure you put. And there is that alternation again that bring all those elements, even if they are not important to the assessment. They create all those, send all those affective meaning that enable a better relationship and a better, more relaxed assessment process. That are very important. And of course, from here now we are thinking of what it means for in terms of building a robots that either respond to those and create those affective circumstances, but also if a robot had to do some type of assessment, what does it mean in terms of using touch from their side. But touch is very complex. And I think we need really to go away from just thinking to empathic social touch or just thinking to instrumental touch. Of course, they are both important, but they often occur together. And if we want to build technology for that, we need to understand it again across the interdisciplinary community, not just us as a technology researcher. And so it's very important, and I think again here we are studying it in the context of robots, but we are observing similar learning across other, as I say, across a variety of sectors where we are looking at touch, and textile is one of them. And I stop here, and I thank all my collaborators, and thank to you for listening to me.
Thanks a lot to you, Nadia. I'm going to clap on behalf of everyone.
Thank you.
Thank you. And I am going to stop the recording now so that people maybe feel more comfortable about asking questions.